The broadcast is now starting. All attendees are in listen-only mode.
Good morning, everyone. This is Deanna Mitchell again with Leading Age Michigan, and welcome to our Wednesday Safe and Calm webinar. This is day 92 since the governor first declared a state of emergency for Michigan. And as we watch the caseload and death rate continue to trend downward, everyone is kind of trying to figure out where to go from here. Residents and staff are tired and yearning for some return to normalcy. But right now, the big question is what the safe steps, next steps might be, and whether or not to some degree we're going to have some sort of new normal. So our agenda today is focused a lot on our advocacy, where we are and have been working on the major issues that impact our members. And then, of course, we'll also spend some time reviewing what the current directives are with a focus on nursing homes, AFCs, and HFAs, considering all the recent changes. With all those changes, there seems to be more gaps and lack of clarity than before. Last week, we focused a bit on independent living, and we're going to talk a little bit about that in terms of advocacy as well. So right now, I'm going to turn the presentation over to Dalton Herbal, our Director for Advocacy here at Leading Age Michigan.
Good morning, everyone, and thank you for attending this morning. I apologize if you hear any sirens in the background. That is me, so I apologize. Thanks for being here today. Today we're going to be talking about a couple of things. We're going to start with what we've been doing around the executive orders and what our asks have been for clarity. And by asks, I mean our recent asks. We have been working with the department pretty much hand in hand because things seem to come out so rapidly, and then there doesn't seem to be enough detail for operators to effectively operate in the space. So 2 days ago, we submitted a formal letter to MDHHS Director Robert Gordon. You'll see that the exact letter on the next slide. We're not going to cover it in detail by me reading it, but in that letter, we asked them to take a look at Executive Order 108 and our concerns around independent living facilities and HFAs and what that visitation process looks like. EO 112, asking them to reinstate non-certified employees for use in skilled settings. We have been hearing from a couple of members that when she rescinded that order, it really is affecting the quality of care that they can provide their residents. So we've reached out so we can hopefully get some relief there. And lastly, as we all know, there's been a lot of confusion around what is communal dining, what does communal dining mean in each setting. So if we move to the next slide, we'll see our letter that we submitted. Once again, the handouts are available, so you can download that there. It's 2 pages, so it's not incredibly long, but I don't think we want to spend time reading a letter on a webinar today. And this is just so you can see it. Moving on, we'll talk a little bit about some more details here. As I said, for Executive Order 108, we ask for clarity around independent living visitation and what does the rescinding of the stay-at-home order mean for our providers? Can those people leave the community? We know that they legally have the right to, but should they or shouldn't they? What we have heard so far is that the state is in very early stages of drafting formal visitation guidance for HFAs. And by very early, I mean they're just starting to think about it, which I think our letter helped spur that along a little bit. Executive Order 112, non-certified staff, we covered that a little bit again. We asked the department to consider allowing SNFs to continue the use of non-certified staff. And once again, on the communal dining piece, we asked for guidance on the definition of communal dining and what clarity they can provide us around what communal dining means in each level of care. And so in the past webinars, we've been talking a little bit about Senate Bill 690, which is this big spending bill that the legislature is using to allocate the funds that the governor has under her control and what that means for us. And I just want to provide some clarity as we've gotten a little bit of clarity and a little bit of insight into how the negotiations are going and what are these topics that they're addressing in these negotiations. So firstly, as I just said, the state has $3 billion in a one-time CARES Act fund to spend on COVID-related costs and to reimburse providers for that cost. And the governor has sole discretion of those funds until the 30th. And so this Senate bill is aiming, the legislature is aiming to recommend send recommendations to the governor as how she should spend those funds. Initially, it was done as kind of a political ploy to say, hey, governor, why aren't you spending these funds? But then the governor said, hey, let's come to the table. Let's talk about how we should be spending these. And so right now, the House passed this bill, and the bill includes $1.264 billion of the fund, which means if they spend this money, there will not be that much money left in the $3 billion to reimburse providers for any other thing. And so this is kind of a critical time for us to really advocate and say what our priorities are in terms of the dollars. From conversations we've been having, we know that the bill is likely to be passed, that the negotiations are actually proceeding, and that once it is passed from the House, it actually has to go back to the Senate for approval. So we're a couple of steps away, because the Senate isn't actually involved in these negotiations. The negotiations are between the House and the governor. Next slide, please. I did that a little out of order. So, two main areas that affect providers here. The first is the direct care worker increase in their pay on I think it's every 15-minute basis, they get an increase in pay. And that pay right now is set at $3 an hour, but that pay increase is actually one of the things that is being negotiated between. And it's not if that pay should happen or shouldn't happen, it should happen. What level should that pay be at? Should it be higher? Should it be lower? What should it be at? A couple of things about the bonus payments. They are retroactive to April 1st, and they go to September 30th, and the funds are inclusive of costs. So you will have to take out the cost of these funds once you receive them before they are distributed to the employees. And the example that they give actually in the bill is payroll taxes. You'll have to take out payroll taxes before they're distributed. And in the bill, a direct care worker means a registered nurse, a licensed practical nurse, a competency evaluated nursing assistant, or respiratory therapist. And these people have to be employed or contracted by a skilled nursing facility or an area agency on aging. And those who have previously received the $2 an hour bonus payment will receive an extra $1 or match whatever the level is that they decide. Second, in the bill, there's currently $50 million allocated to establish a grant fund to reimburse providers for their PPE costs and their testing costs. The providers who can receive these funds that are listed here, we've been working hard to get long-term care facilities and residential congregate facilities added to this list, and they have been added to the list. But the terms aren't currently defined in the bill. So that's kind of the next battle where we're going with this fund. And also, we don't think $50 million is going to cut it to reimburse all these providers for all these costs. So we've been also asking for them to increase the funding pool, because $50 million is just not enough, especially when how to fund testing and how to fund PPE in the go forward is going to be so critical to the operations of many of our members. Next slide, please. So this is going to be the first of a couple timeout slides. These slides are designed to give you time to type in your questions. In the past, we feel like we may have been rushing some people and when they've been looking to submit questions. So we're going to take 30 seconds to 45 seconds here, I think, to give you some time to start to think about what questions you want to ask. And we also have some more slides after this. So we'll take some time. In the meantime, I also wanted to mention that the handouts are in the tool here, and they will be sent out afterward. So we'll take some time now for you to think about what questions you may have.
While everyone is thinking, I also just wanted to mention, if anybody is interested in it, tomorrow we have beginning our post-pandemic attorney-client concerns. It's a 3-part live webinar series with Dykema. So if anybody is interested in that, it will be June 11th, June 23rd, and June 25th, each day from 1 p.m. till 2 p.m. So if you'd like to register, you can go over to leadingagemi.org and just click on our events calendar, and it should be the very first event that pops up. So just letting everybody know about that. Dalton, would you like to keep going, and then are we going to ask questions after that? Was that the plan?
Yeah, we'll have questions after. Let's keep going. This slide was really just to give people a little bit of time to think about and type in what their questions will be. Okay, so another kind of hot topic issue, as we discussed last week, the video of abuse that was in the Detroit area really started to spur some momentum about monitoring in nursing homes again. And the Senate Health Policy Committee was kind of sitting on Senate Bill 77, which would establish residents, or would allow residents the right to have these cameras in their home. And 2 days ago, we got a call from the chair's office, and they said they're going to take up and pass the bill tomorrow. It's gotten political, and we need to move it. We don't want to be seen as we're sitting on this bill. It's bad. It's a bad look for us. So what's going to happen is tomorrow they're going to take up and pass this bill, kind of giving the bill momentum that it didn't have before. And I'm going to ask a polling question later on after Senate Bill 77. After I have the discussion, I'll do some brief review. So we're going to get a little detailed here, but it's more so to color what you think about the bill in regards to your response with the survey question I'm going to have. So what does the bill do? It allows a resident or their representative to install electronic monitoring equipment in their room. This equipment needs to be paid for by the resident, and it also needs to protect the privacy of others in the nursing home to the best extent it possibly can. You must get the consent of any roommates if you have one, and the roommate can recall their consent at any time, or the roommate's representative. And notice must also be posted on a door or in a public place, so anyone entering the room knows that they may be monitored. The evidence is also admissible in civil and criminal court cases. So what are our responsibilities as providers? You must provide reasonable accommodation for this equipment. You must reasonably provide a place to mount the recording device. You must give them access to a power source, and you must notify residents that they have the right to install a camera if they choose to do so, or an electronic monitoring device. It doesn't necessarily need to be a camera. You can ask residents or representatives to provide the request in writing, and you cannot refuse an admission or remove a resident because of their request to install a device. Senate Bill 77 also only covers SNFs. It doesn't include any other setting. So what did we do when the first bill initially came out? So we had been working with the chair. We kind of knew that they were going to sit on the bill in committee. The bill was being taken up more as a favor to the bill sponsor. So what we did is we submitted this letter for testimony, and during our testimony, we highlighted concerns about residents' rights, specifically around decision making. What is the process for those who can't make their own decisions because of various reasons? Resident privacy concerns, HIPAA concerns, We felt that there should be a renewal period so that they have to notify you every, say, year or so, or even less than that, that they'd still like to have the camera, because otherwise roommates or the resident may forget that they have it and may not wish it's there. And we also asked for the establishment of an implementation work group so that we can work through what's the best way to transition into a period with cameras, because a lot of our facilities aren't built with places to mount devices. So that's kind of what we asked for in late January. And going forward, we'll continue our advocacy. A little bit more about the bill coming up on the next slide. As I said, the bill is going to be taken up and passed tomorrow. And it's moving because of very political reasons, because of this video and the bill sponsors kind of rabble-rousing of the community. The Senate does not want to be seen as sitting on the bill. They're very much intentionally moving the debate out of the Senate to the House so that they can show that something has been moved. The debate will happen in the House, so we still have time to respond. And so this is where I want to try to do our first polling question on one of these webinars, and we hope to do more going forward. So the question is, how do members feel about the potential of residents installing their own equipment in their room for monitoring purposes? 1 in this poll will represent uncomfortable and 5 will represent comfortable. So Blake, if you could help me with the poll, I'd appreciate it. You could bring that up. I believe you just have to click the screen and then we'll end the poll and we'll read out or show the results here. We'll give it a little bit of time, unless I believe you may see the percentage of people who have responded, Blake, too.
Yep, there we have 54% so far. So yeah, we can give it another 30 seconds or so and let everybody go ahead and click on their answer. It's not showing up like it typically does for me though.
I see it on mine.
Oh, okay. See, I still see. Oh, that would be why, because I have the PowerPoint up. Duh. All right. So we'll just give it a couple more seconds here and then we will close it. It looks like we have about 65% of people who have voted. So again, you just have to click on any of those. All right. Do you think that's good, Dalton? I'm not seeing any more movement really.
Yeah, if we're close to 70%, the bill does only apply to SNFs, so it's not relevant for every provider group on the call. So
sounds good. So we will close that and then we will
show the results.
Yeah, we will share those.
Okay, so I think a majority are in a 3 or below, so that kind of gives us a good perspective of how people are feeling about cameras right now.
Right,
Good.
so
Thank you for participating in the poll. We hope to have more going forward, and we'll use that information in the go forward. Next slide, please. So a couple of things before I end the advocacy portion of our presentation today. We also wanted to let our HUD providers know that Katie Sloan Smith, the president of Leading Age and CEO of Leading Age, submitted a letter to Secretary Ben Carson of HUD. And the letter calls for HUD to release the remaining CARES Act funds that they have not already. That would be $200 million in Section 8 funding, $50 million for Section 202 housing, and $10 million for service coordinators. The funds were issued in late March, so we feel that the funds are well overdue, and that we will, as Leading Age Michigan, be forwarding this to members of Michigan's national delegation to hopefully get the ball rolling and provide some relief to our providers. Lastly, we also wanted to let you know that we are monitoring Senate Bill 956. This is the bill we've talked about on the past 2 or so webinars that disallows nursing homes for caring for or admitting COVID positive individuals. It also forces the department to establish 8 regional kind of care facilities for COVID, 1 in each HSA or health service area. The department has looked into it. They've felt that they have to respond to it because of pressure that has been publicly put on them through the Senate Oversight Committee. They're working on a response, but they just looking at it initially, they know that it's going to cost the state a lot of money to implement. The bill is also being currently just kind of frozen in committee, similar to how Senate Bill 77 was. This is really because it's really political. They're trying to negotiate about other things, and they don't want to do something to embarrass the governor or the department or embarrass the legislature if the momentum swung the other way. And so for now, we're kind of monitoring that bill, and we'll see where it goes. All right, it's questions time.
All right, so right before we get to the questions, obviously, Leading Age Michigan each year is thrilled to spotlight the new and innovative programs and services displayed by our business partners at our Solutions Expo. During this historic and challenging time, we would like to celebrate our business partners who have maintained their commitment to our members during our short delay. Please thank our business partners by supporting their programs when you are in need of their services. Here's just the beginning of the list of people who have stuck with us throughout these difficult times and will be with us at our annual conference and solutions expo once we get that back in order, I guess I should say. So now we do have a few questions. So I will just start going down the list here. On June 15th, salons in our region are allowed to open. In independent living, are we allowed to have our beauty shops open and the stylists come in, or do they fall under the visitor restriction that lasts until June 26th?
Hi, this is Deanna. Independent living is a very gray area. We've had this question from several different kind of provider types. For nursing homes, AFCs, and HFAs, I think it's clear that that would violate the unnecessary personnel in the building order, and the non-group requirements as well, no meeting in groups. It's a little bit less clear for independent living. I do know of one or two sites that are thinking about opening salon services in independent living, but right now, technically, I think that although it's gray and although we're seeking guidance from the department, I think the better part of valor is that unnecessary personnel are not supposed to be coming into the building, so hairdressers would be included there, and group activities should be frowned upon as well, even though that's not explicit in the order. So again, for independent living, it's gray. I know some people are going there. But we think that does increase the risk. It's clear for the other settings, it would not be appropriate.
I also want to note that they are working on some kind of visitation guidance, which I think may help clear up some of these issues.
Hopefully, yes.
All right, thank you. Is there anything in the works to add compensation for HFAs and AFC workers? Paying an extra $3 to nursing home workers and giving people $600 in unemployment makes staffing very difficult.
I haven't heard anything about that. I've heard the debate is largely regarding what the level of funding should be. There's still additional funds available in that pool, so that is potentially something we should be asking for. So thank you for the comment. We'll go ahead and bring that to the attention of some people to get the temperature of what they're thinking.
All right. How do the current rules relate to window visits at both SNF and senior living? We have families really wanting to have these.
Well, I think that some facilities have done closed windows visits all along. And the only thing that really prevented that from happening was the stay-at-home order, where persons were not supposed to be leaving their homes for such visits necessarily. However, there is no preclusion to a closed window visit now. You can go ahead and do that, and hopefully we'll have outside visitation soon. The department is working on that as well.
All right. Thoughts on what we should do in the AL setting when families want to install cameras? We are finding them in the rooms now.
I have definitely heard of cameras being installed in almost every setting. Uh, I don't know the exact rules. Deanna may be able to speak a little bit more to the exact rules, what to do with the cameras, but at least my thoughts are that if they have the right to do so, there at least needs to be some form of notice posted or some form of formal approval given so that people who go into the rooms know that they're being recorded. Deanna, do you know anything about the specifics?
To my knowledge, and this isn't necessarily very deep, I do have some experience with facilities with cameras, but there is nothing explicitly allowing them or explicitly denying their use. But it would be hard at this point to stop families, I think, from placing cameras in these settings. And considering the media, you can't really blame them to a large degree. I think that a prudent HFA, AFC, or nursing home would have policies and communications with the residents and their representatives and families that would identify the parameters, because there are privacy issues. And one of the major issues is a family member who wants to watch a resident and the resident doesn't necessarily want them to. That's one of the issues that we face going forward. So I think that you've got to really take into consideration the rights of the resident and whether or not they are competent to make those kinds of decisions for themselves. And I would err on resident rights here. But having explicit policies and communicating them to family, staff, and residents, I think is probably your best action at this point.
All right. Can the facility refuse to assist in the mounting of the device? Example, our IT department helps with installing some other devices.
From the way the bill reads, I would say yes, but you can't do it so that it essentially isn't you providing reasonable accommodation. You have to provide an area for them to mount the device, but you don't have to mount the device for them.
All right. Senate Bill 77 to install an electronic device. Who would pay for extra power outlet without use of an extension cord or power cord?
For the power, I believe that would actually be on the resident. They're supposed to include all costs associated to the monitoring device to the resident. So it would be the resident who pays.
All right. And
that might be a bit hard. I don't know how you would do that, but that might be something to really take up, Dalton, because I don't know how. I mean, I suppose they could just provide a standard charge for extra power, but I'm not sure how that would be operationalized.
Yeah, that does seem difficult. That's something I'll ask around for a little more detail. The bill is fairly general right now, so there's none of this detail in it, and that's a good point. I'll bring that up.
All right. This one's more of a statement and just says my records indicate 21 designated regional hubs for nursing homes.
That's correct.
Yes, that's correct.
I think that some people are saying 20, but I've heard 21. I haven't counted them recently.
All right. Do you have any idea when the visitation guidance will be released?
I heard in the next couple.
Go ahead, Dalton.
I heard in the next couple weeks, but that's not really the greatest of timelines. I know it's fairly early. I don't know if you. What were you going to say, Deanna?
I know that they're working on it. However, you know, the state is the state. One would hope, and they're working hard. I think that they were actually thinking that they would be closer now than they are. And I do think that they expect to have something soon, but we'll have to see how that plays out.
All right. And then someone said, currently many of our outlets are already maxed in the room already, as far as the cameras go, I believe.
Yeah, that sounds like that. Okay, that's good to know. That's another point to bring up. It just does provide a reasonable accommodation to a power source. So what would reasonable accommodation mean?
All right, and then it said Dave had said LMI sent a letter requesting an answer last week. Do you know what that was pertaining to, Dalton?
We sent a couple letters last week.
He says for visitation.
Oh, okay. Yes.
All right, so other than that, that takes care of all of our questions for now. So I believe we can go ahead and keep moving forward.
Thank you for your
Okay.
questions and feedback. I appreciate it.
Okay, so now we will we'll look at a very brief situation update. Moving on to the next slide, here are the world statistics as of Monday, June 8th. Note that most portions of the world, the spread seems kind of the same, although it is still growing in South America and the Caribbean areas. This data is from the Financial Times, and it was one of the few sites that I found that actually discussed the cumulative cases in comparison to active cases. Most of the data that we find in any area has some real limits, and it's often hard to get a really clear current picture sometimes. One of the things that I noted was that active cases, though, are just less than half of the cumulative cases. So that is something to think about. In other words, we still have half of the cases actively ill now. That might still cause some concern moving forward. So the next slide shows the statistics for the U.S. as of yesterday, June 9th. These again are cumulative cases to date only. And you can see that the intense areas are still in the east with high numbers in Texas and California. But you have to remember that those are the high population states. There is some growth actually in caseload in several southern and western states, but it's not quite caught up yet with the early high transmission rates that have been found in the east. This slide I thought was interesting. It shows the U.S. cases by day, and we included this to provide a look at that trend line. There are the usual spikes in caseload you can see, but there's always a bit of going up and going down on a day-to-day basis. But one thing to pay attention to is that the trend downward is not as steep as it is in Michigan at this point. And we think that the numbers reflect that some states are actually still going up, and that balances against the others that are going down, such as Michigan. But it also means that that people who are traveling, if there's high transmission in other states, it could be an issue coming forward as we try to eliminate this virus. This slide is the most recent update to hospitalization per age group. There's no real surprises here, but we note that the rate grows with age and it peaks in the over 85 group. But it's important to remember that children have been adversely affected too, and some of them have actually died from the disease. So it's still a serious pandemic out there. These next two slides are our weekly run of the 7-day rolling average for the first is, of course, for daily Michigan caseload. You can see that it continues to trend downward, and that's a very good sign. And we've limited our graph here to the last 60 days. So as we move forward, you'll see that the left side of this graph will start to fall off day to day. And the next slide shows the 7-day rolling daily average new deaths for the past 60 days. And again, there's always some up and down, but that has really been going down in the last week or so. So that's a very positive thing. Okay, so we're going to move on to some other topics. And a big one right now is testing and reporting. So we've kind of created a separate agenda item for that for each week in this future, at least for now. So MDHHS holds a testing and reporting work group meeting almost daily. although I think it might have moved to 2 to 3 times per week. So last week on the webinar, we talked a bit about staff from Mackenzie or MSU. Those are contractors with the state who were contacting each nursing home to validate their data that had been reported for COVID, and basically their understanding of the reporting requirements. And most of this was because much of the data at first seemed really flawed. Currently, these groups are consulting with the state on the reporting piece itself. And the state reported yesterday that almost all of the contacts with nursing homes were done as of yesterday. I think they had just a few to do yesterday and today. And we also noted that the department has cleaned up the list of nursing homes. And one of the problems with the reporting rate, it looked kind of low for a while, was because there were assisted living facilities in the group, and also some nursing homes that were closed. So obviously they would not be reporting. So since they cleaned up the list, they find that 99% of facilities are actually submitting their data into EM Resource. Yesterday, they also noted, the department said, that the data will still vary from what is posted on Nursing Home Compare, and I'm not quite sure why that would be, since they aligned many of these measures with the CDC NHSN reporting. But we do know that the NHSN data will always be at least a week behind, and Michigan reporting is required to be daily. So that might be part of it, I'm not sure. We'll look into that some more. I'm told that the department plans to post frequently asked questions about the EM Resource reporting piece, and that they will also be issuing a report on their data validation findings. So we will definitely be looking at those things. One of the things that the group is working on is also critical staffing support. They are anticipating that as testing moves forward, nursing homes and actually other residential care communities may experience high numbers of asymptomatic positive staff, and that could provoke, an acute staffing shortage. So the department has been working with a large staffing agency that apparently covers, if not the whole state, a large part of the state, who they believe might be able to help. So they are considering developing a template contract that includes rates, which of course we've not seen yet. And apparently this agency has the ability to cover all kinds of staffing needs across all long-term care settings, not just nursing homes. So we'll be watching this to see whether or not the cost is going to be prohibitive or not. And the states also briefly discussed the idea of developing a crisis staffing team that could be rapidly deployed. But at this point, it seems that that's just an idea. In terms of testing, the National Guard is now working on the final 25 counties, and then the baseline nursing home testing will be completed. The National Guard is available to the state now until about mid-August, so it's not clear what they'll be working on next. The real challenge for the state seems to be to figure out what ongoing testing should look like, and they are beginning to really consider that. There is also an AFC HFA testing work group, and we believe that they're working on some of the same protocols as the nursing home group have implemented, and they have started testing in some areas, although we've yet to see data. So as we discussed last Friday, MDHHS has made some rather large updates to the reporting website. They now report confirmed and probable cases separately by age, gender, and race for areas throughout Michigan. They've separated the testing data also by whether it's a diagnostic test or an antibody test. And of course, they still report all of the cumulative cases and deaths by date. The inclusion of probable cases is a bit of a controversial area, since some states do not do that at all. but Michigan now will report cases that do not have a positive lab finding as presumptive, as long as there are symptoms or a possible lab report that they think would be positive, along with an epidemiological link. And that means some contact with a known positive case. Or they'll also list it as probable if the death certificate notes that COVID is listed as the cause of death, but there was no positive lab finding. And it's important to note that these cases are not just added to the overall confirmed numbers. I think it's important that to know that they are listed separately so that they're not skewing our numbers, more or less. And the website link is right there at the bottom, and we will be putting that on our Q&A as well. So here is a part of the new reporting page on the website. They're reporting positive tests by county. Reporting it as the number of tests per 100,000 persons. And you might note, if you look at these are Excel files when you click on those kind of teal colored links. The highest rate in any county is about 9 to 10% still. I mean, this is across, the entire population, this testing. So when we looked at it, it didn't really seem to tell us much. The diagnostic test, which is the last link there, includes results and the county, in each county, and it kind of gives you the same thing, but it also gives you the number of positives. But all the data is really cumulative at any given time, so it doesn't give us a very good picture of the current state of things moving forward. So it'd be nice to see some better data, but it is improving as we go forward. And now that AFCs and HFAs are beginning to report, we're kind of waiting to see what kind of data that looks like. Have not heard any reports about it yet. It may take a while for them to hammer out some of the bugs and issues that occurred with nursing home reporting up front. So it might be a while before they're publishing that. Moving on, of course, last week they started reporting nursing home data on Nursing Home Compare. Here's a portion of that main web page and where you can find some of the data that's been posted to date. The first bullet includes the findings from surveys starting on March 4, and this is a huge zip file that leads you to surveys by facility, but they're categorized by CMS region. So it takes a little bit of work to get to the data here. In that file, it shows the F-tag findings with a link to the 2567s for 152, I'm calling them infection control surveys in Michigan, but a lot of them were probably FRIs as well. We're going to talk a little bit more about that later. The second link takes us to the actual data that's reported to the CDC through NHSN, and this data is in a very long Excel file. You can enter your facility name and find your data, but it's really hard to look at, and it takes a lot of work to get a summary data or look at any other trends. If you want to review the data requirements for all of this, it's all posted in QSO 2029. And here's the high-level categories of requirements that is being reported on Nursing Home Compare via NHSN. Members can, again, pull their own facility data and look at this. They can look at other facilities as well. If you can just put a facility name in and it'll come up. But it's really, again, hard to identify the trends. Moving on, there is this option where you can look at caseload data. If you click on that second bullet on the front page of Nursing Home Compare, you can scroll down and you'll be able to enter a zip code and a map of the area. And a dot for each nursing home comes up, so it's much smaller area than obviously the map of the United States here. And you can see the caseload numbers. If you click on a dot, you'll have the name of the facility and the caseload numbers. Actually, as I looked at this, what was a bit surprising to me is the number of nursing homes that are in the east versus the west. But I was able to pull up some nursing home data looking at this. It's kind of a quick way to look at basically just caseload and deaths. So it's rather interesting if you want to take a look at how your facility is being portrayed. So I took a brief look at the nursing home survey reports for the 150 facilities that have posted findings on this website. So Michigan supposedly has done 368 of its 442 on-site surveys, and that was as of May 31st, but only 150 of those are reported. And you can look at those from the front landing page. In those 150 surveys, there were only 9 cases where infection control was cited. There was a wide range of citations, several with abuse and neglect, several with reporting abuse and neglect issues. The infection control cases were mostly about hand hygiene. I think there were 2 cases where the overall infection control program was inadequate, especially in terms of surveillance, and that was very clear from the survey. But mostly, it is about those little things that providers often get cited for, hand hygiene. Okay, so we're going to pause just for a minute and again give you some time to formulate any questions that you have. We want to make sure you have time to think about them. We will answer them in a few minutes, not right now. We want to give you some time to do that. Remember, you can enter them into the chat box and we'll review them at the end of this section. So Blake, are there any other announcements that you want to make while we're waiting?
I do not believe I have anything else. Just a quick reminder, obviously we will have another COVID webinar this Friday at 11 a.m. Eastern Standard Time for additional updates. And then in case anybody did join later who was not here earlier, if you are interested, we have a 3-part live webinar series coming up with Dykema. It starts tomorrow. It is about post-pandemic attorney-client concerns. And that will be a 3-part series, like I said, June 11th, June 23rd, and June 25th from 1 p.m. to 2 p.m. each day. And so that begins tomorrow. If you'd like to register, go ahead and hop on leadingagemi.org, go to our events calendar, and you can register there.
So we're going to give you a few more moments here to start formulating your questions, start entering them in the chat boxes, and then we will, into the chat box, we will start to answer those a few more minutes down into the webinar. Okay, Blake, why don't we move forward?
Sounds good.
As people are formulating their questions. We were going to move on to practice and guidelines, which is always kind of a major issue for us going forward. So one of the big issues that we keep talking about is the reopening of facilities. And we know that seniors are struggling with the isolation that continues because of this restricted visitation. And yesterday, the federal administration issued an updated reopening guidance that's based on 3 phases. And these were all part of the plan that was distributed several weeks ago. Basically, yesterday's guidance was about promoting and a resuming of normal healthcare utilization and considering when to do that. And according to the guidance, that's only going to occur after regions meet phase 2 requirements. So they put out these phases a couple weeks ago with gating criteria, but they anticipate that hospital care, regular non-essential care, elective care cannot be fully opened until regions meet phase 2. Each phase has a set of what they call gating criteria. You can't even think about opening until you demonstrate a downward trajectory of flu-like illness, positive cases, and that you get to a situation where hospitals have the capacity to treat all patients without having to rely on any crisis care, and along with a robust testing program in place for everyone, including antibiotic testing. Core state preparedness, there has to be testing and contact tracing capability, again, healthcare system capacity in case there's a surge, some protection of workers, and a protection of users of transit systems, excuse me. So this guidance that came out yesterday, the link is at the bottom. We will include it in our Q&A. So when we look at all phases here, all phases have continued hygiene requirements, a recommendation to wear masks in public. All three phases have a continuation of masks. Anyone ill must still stay at home. Employer policies for social distancing, etc., are going to continue. You'll note that phase 1 and 2 have strong recommendations that those who are vulnerable should still shelter in place. So that's one thing that's going to impact not only our visitation, but also our ability for seniors to move out into the community freely. Phase 1 and 2 still says that people who are vulnerable, in other words, have high comorbidities or age issues, should continue to shelter in place. Phase 1 feels like pretty much where we are now. Elective surgeries can resume, senior care visits are still prohibited, and groups of more than 10 are still to be avoided. Phase 2, the language is not very, there are no distinct measurable criteria for these pieces. That's one of the challenges that I see with this guidance. Phase 2 doesn't look a whole lot different to me, except it has to do more with requirements about cases trending downward, how to slowly open businesses with precautions, and healthcare as well. So phase 2 is really kind of a continuation of phase 1 in a way where things can slowly reopen because of continued positive trends in caseload. Phase 3 is the last phase on the federal reopening guidance, and the vulnerable now can move out to the community, practice social distancing still, and continue to have minimum time in crowded environments for anyone, including those with a low risk, unrestricted staffing of work sites, etc. Senior care visits and hospital visits can finally resume. Hospital visits have already resumed in Michigan, we know. Large venues still have to have social distancing. Restaurants, bars have to have increased room so that people can maintain a distance throughout. So for healthcare services to fully open, according to the federal administration, there has to be capacity for surges, the ability to rapidly reopen alternate sites. And I think that's an important point as we move forward, especially in Michigan, because we have those regional hubs sitting out there, and we have those alternate sites that are not really being used right now. But if you take them down and we have a second surge, that could be a problem. We have to have the ability to prioritize care to at-risk populations, and to open facilities, there still must be segregated non-COVID screening areas, sufficient resources and PPE, the ability to track patient outcomes. Dedicated COVID spaces are still expected both in hospitals and in other healthcare kinds of facilities, with minimum visitation along with ongoing screening of staff, visitors, and residents. There also has to be some testing considerations. You can move on, Blake. There's nothing really surprising here in this group of considerations, and of course PPE has to be available as well. Staff still have to be able to wear surgical masks at all times. unless higher level masks are needed. So if your staff are wearing, your direct care staff are wearing cloth masks still, if you don't have enough PPE, you need to look at that. Patients and visitors can still wear cloth coverings. And of course, PPE has to be conserved using the CDC strategies. So in order to reopen, there has to be a sufficient workforce to respond quickly to any surge. Staff screenings and dedicated staff for COVID care is a must. So you still have to be able to ensure that the staff taking care of COVID patients is separate from those who are taking care of non-COVID. CDC return to work guidance still in place, and of course sanitation considerations that have not changed. So as we look at this guidance to reopen healthcare, it doesn't really seem to be a lot different from what we're doing now. It's simply a movement slowly to reopen certain things such as visitation as transmission decreases. And that seems to be what the governor is doing, as healthcare is now open to some non-critical and non-essential, in other words, critical care. And hospitals are now open to visitation, although with some restrictions and safeguards. So the administration has, the federal administration has put all of this out as a patient guide, and we will include a link to that guide in the Q&A. So where is Michigan in its reopening plans? No, move forward, Blake. For senior care. It's still a work in progress. As we discussed last week, there are 3 LARA work groups developing plans for this, and these work groups are now coordinating with MDHHS as well. The high acuity group, which includes nursing homes, are recommending criteria that falls very close to the CMS recommendations. So we want to make sure that people hear that. We anticipate that the assisted living type facilities, including HFAs and AFCs, will follow suit for the most part. So we anticipate that the assisted living reopening guidance will track along with the CMS guidance as well. And the third work group, which includes independent living, is recommending the special rules should not apply to them. And we'll have to see how that goes forward. So considering that the recommendations for nursing homes, HFAs, AFCs, and perhaps unlicensed settings will follow, or may likely closely follow, the CMS guidance, we will post that guidance again in our QA document. Note that the state can determine to open visitation across the entire state all at one time, by region or by facility. And the amount of visitation requirements as they loosen, it depends not only on the case status in the community and the nursing home, but whether or not new cases develop. Visitation progress kind of stops when new cases are found. And of course, you still have to have all the other resources that we would expect. And this guidance includes a detailed grid. We suggest that you review it if you have not already, and particularly if you are an AFC or HFA. So we're going to pause now for a few minutes for questions before we move on to executive orders, which is kind of a big thing as well.
All right, and then just before we get to questions, again, Leading Age Michigan would like to extend our sincere appreciation to our generous business partners who continue their support of our annual conference despite it being temporarily postponed. We look forward to your continued collaboration, and we remain grateful to all of you. All right, so right now I actually only have one question, so if you do have any questions, feel free to type those in while I'm asking this one. So they said we have to report daily, one second, I'm sorry, I'm trying to, okay. So we have to report daily, but the death certificate may not come for a while. Do we go back and change our numbers if we find COVID on a death certificate? A bigger issue is the facility often does not get the death certificate. So who is reporting? Me, the funeral homes, who?
I have to be honest, I do not know the answer to that question, although we will forward it to the department testing and reporting work group. and we'll get some clarity around that. I do believe, I remember this coming up, I just don't remember the answer.
All right. This one says, just a comment, weekly staff testing and testing all residents each time one resident has any COVID symptoms is not very feasible, both from a financial perspective and an implementation perspective.
And we certainly understand that. As we move forward, I do think, and many of us think, that the CMS guidance is a little prohibitive. So that although we're not 100% sure that the testing piece of that guidance will be adopted by Michigan, but I think the visitation opening pieces, in other words, what has to happen in order to open up visitation incrementally, will probably be very similar.
Okay. Does SNF need to test all staff weekly per CMS guidelines?
They do not right now. The CMS didn't really put out a formal directive to do that. They put out a set of recommendations to the states. They put out a minimum set of recommendations for testing, and that is included in that. But the state has to adopt it first. And then we have to make sure that CMS will agree to it, more or less. So it's still a process. The state's working on it. We'll have to see how it plays out. Right now, there are no testing requirements at all, technically. However, you know, the better part of valor is, of course, to make sure that your staff and your residents are safe. And the state, of course, is promoting testing through its baseline initiative. But the next steps are still up in the air.
All right. Do the residents need to be tested weekly? The health department does not agree with ongoing testing in our community.
I think I just answered part of that. We have discussed the inconsistencies in the health departments from area to area with the state before, and they've kind of downplayed that with the idea that they thought that probably wasn't true. So if there is inconsistencies in public health departments locally, continue to let us know that, and we'll continue to feed that to the department. However, right now, there are no testing requirements, but I believe that the state in the next few weeks will come out with something.
All right. That is all the questions I have right now, so it looks like we can keep moving forward.
Yes, okay. So our next topic is very brief. It's about the temporary waivers. So as things start trending downward in terms of caseload and things are opening up, CMS is beginning to consider what to do with all of the waivers. There's 130 Medicare, 150 Medicaid, and they're calling it a glide path. In other words, they're expecting to take their time, and they're currently reviewing claims and Advantage Plan and counter data to determine how these flexibilities were used and whether or not they considered a positive or negative use of them. Obviously, the use of telehealth services was dramatic. There is an anticipation that some of these waiver flexibilities will become permanent, such as telehealth, and we're hoping the 3-day hospital rule for SNFs. But there will be laws and rulemaking that might be required for some of these. So anticipate that you're going to see some information about this as areas open, but CMS is going to take their time. One of the things that we wanted to bring up just briefly is the WHO, the World Health Organization, and their statement about asymptomatic illness, which was very positively received by the world. They stated that asymptomatic transmission of this disease is very rare. They kind of backpedaled that yesterday and said, well, that's not a definitive answer. They need to review more data, but as they look at the data, they still believe that's true. And detailed contact tracing has not found any significant spread from asymptomatic people. There are still some other experts that believe that it can create up to 40 to 60% of all transmissions. And what the WHO didn't do is they didn't really put out the data to support this. So it's possible that we could see some lightening up of restrictions based on this information, but not until they issue some reports and data and the CDC can look at it. So I thought this might be a good time to discuss some of the executive orders with all of the changes. We have updated the list on the website, and in response to member requests, we identified all of the rescinded EOs and highlighted those that are still current and of interest to senior care providers. Since Friday, the governor put out 4 more orders, but they don't apply to senior care directly at all. So we don't really need to talk about these. I do continue to list all of them to make sure I don't miss any, but these are not pertinent to us. But going to the next slide, we want to talk about those that still apply. And I really put a lot of detail in these slides because I want to make sure that everything was covered if you wanted to review it, but I don't intend to read this to you in any way, shape, or form. But the earliest slide that pertains to our members is 2020-36, and this is the order that really speaks to all businesses, but it protects workers who stay at home and includes an awful lot of basic requirements for how to treat employees if indeed they have to take medical leave, and the fact that you can't discharge an employee simply because, or discipline them who choose to stay home when they are at risk for infecting others. So this has been a long-standing order, and it is still in place and is likely to be so until the end of the pandemic. The next is 2020-61, and this is such a big order that it took me 2 slides to summarize the pertinent provisions. This first part is kind of well known. Advanced practice nurses can work without medical supervision within their scope of practice. Other nursing professionals can do additional things as well. You can allow students and other kinds of trained professionals to work as extenders under supervision, and temporary licensures for professionals that are out of state. That's still in place. The next part of 2020-61, though, is about facility and professional liability, which is an important piece. That's still in place. This is also the order that provides flexibility for professional licensing requirements, certification for life support, fingerprinting, which is still in place. Flexibilities about fingerprinting, although the fingerprinting piece, remember, you still have to do some aspects of that. So we encourage everyone to look at the rules for that that are on the website. It has to do with iChat. You still have to do that. You move forward, Blake. So one thing about Order 2020-61 is that it provides, actually suspends continuing education needs for healthcare professionals. And this is language that came out of Laura about that. And they included June 9th, through June 9th, 2020. They'll recognize hours worked. You have to be able to prove that. You have to be able to have some documentation. It can be a self-attestation. And that's for using your hours worked in response to COVID as CEUs. The thing about June 9th is that my documentation shows that this executive order is open throughout the duration of the pandemic. And Laura put June 9th on here, so we're going to have to look into that, what that's about. Another piece is that you have to show that these hours, you can attest to them. You can have an attestation from a human resources administrator or some sort of direct supervisor. You don't have to necessarily work for a hospital or a nursing home to do that. So any kind of self-attestation, if you are spending your hours in support of COVID in some way, doesn't have to be direct care, you can use these as CEUs, and 1 hour worked equals 1 hour of CE, which could be quite a bit for some people. Then next slide shows 2020-95, which is an extension of the famous 2020-50 regional hub order. It continues to focus on each long-term care facility, including non-nursing homes, working to have a dedicated unit if possible, but it eliminated that 80% rule. The pathways remain unchanged. Regional hubs continue to be used only for nursing homes and hospitals. Decisions about where to place a patient should be based on patient safety, safety of other residents, wishes of the family. This order is still in place. A recent conversation with the department included this topic with the idea to extend regional hub use to AFCs and HFAs, and we thought that members would be for that. Although we understand that some members have noted that their residents would be better off staying with them perhaps. But this could be an option for those communities where there's a sense that they would not be well served in their community. The community doesn't feel like they can care for COVID patients very well, and it might place their other residents at risk. And of course, the reporting requirements for nursing homes, AFCs, and HFAs is included here, and this whole thing terminates on June 17. 108 extends the visitation requirements to 6/26. There's really not much new here. This is the piece that is a little concerning because independent living is included, but this is also still current. Okay, pause for questions. We only have a couple more slides. We are running a little late. We will try to be expeditious. So if you have questions, please start putting them in now. We'll give you a couple seconds to do that, and then we will move on to just a couple more slides before we end for the day. Okay, Dalton, let's move to the next slide. I'm sorry, Blake. So the Bureau of Professional Licensing and CEUs has put out some information that CEU hours to gain licensure renewal while the emergency declaration in effect that's not been rescinded. That's still current. I'm sorry, that's a mistake. I will fix that on the slide before it comes out. And you can recognize those hours spent responding to COVID again through June 2020. So that's very confusing, and I think we talked about this. So expect some audits, expect to have sufficient evidence. And apparently this is a repetitive slide. So let's move on to the next slide. Last but not least, we have the April 30th LoRa FAQs. These are all still pretty current, but we are hoping to have some information here about outdoor visitation. Some of our members have heard informally from the department that outdoor visitation is currently being allowed in AFCs and HFAs, but it is not been in any formal guidance whatsoever. So we're hoping that we wanted to give everybody a sense of the current pieces that are still in the FAQs, but we're hoping to have some guidance about that shortly. Okay, sorry to hurry at the end, but let's now move on and see if there are any final questions.
All right. So let me go ahead and pull those up. All right. As we try to move out of phase 1 in Southeast Michigan, can we decide not to accept a brand new COVID positive admission?
You must have a dedicated unit to accept it. You must be able to feel as if you are able to serve that person. Personally, I think we would be very reluctant to admit a COVID resident to a non-COVID facility at the time. I think that you could make a case for that. But you need to feel comfortable. And again, you need to look at the entire kind of circumstance around you. Is there a lot of community transmission around you, and yet you don't have any COVID people in your facility? Do you want to reintroduce that? What else is happening in terms of your relationship with the hospital? Does the hospital have some alternative settings? It's something that you should work out with the hospital in consultation with the resident, the family, and the hospital. I do think that you could have a good argument for not taking a COVID positive patient especially if you don't have any COVID positive at the time.
All right. What are your thoughts about whether the state will extend after June 26th?
The June 26th date, and you'll have to forgive me, all those things run together in my head, is about visitation. Am I correct? If that's the case, I think that they're going to open up visitation slowly, but I'm not sure what that's specifically going to look like. It might just be outdoor visitation at first by appointment. That's what some other states have done. I do think that it would be very slow if they open it. Even the federal requirements has very limited visitation, if any, until phase 3 of reopening. So I would expect to see some changes, but it might be as small as for outdoor visiting.
All right. I do not have any other questions. So we would like to thank both Deanna and Dalton for all the content that they put together today. If you would like to reach out to any of them, obviously you can see on the screen right now, we have Deanna's, Dalton, and Laura Funch's email. We also have the Safe and Calm. If you want to send anything there, that goes to multiple emails, so multiple people will see it. We would also like to thank, I believe we had right around 70 members and participants that took time out of their busy schedules to join us for today's webinar. We appreciate everything you do each and every day to support your staff and provide quality care to your residents. We are grateful for your continued support, and we are here for you when you need our assistance and resources. Again, just a quick reminder that we do have another COVID webinar on Friday at 11 a.m. and another reminder that we have the post-pandemic attorney-client concerns. If you'd like to register for that, that begins tomorrow at 1 p.m. The handouts, recording, and Q&A will all be sent, I would assume, within the next couple days. Other than that, that's everything I need to take care of. Deanna, would you like to say anything else?
No, I think that that's it for the day. Be safe, everyone, and have a good day.